Let's get started. Good morning, everyone. Welcome to Women and Bladder Cancer, where we are and where we need to go. A candid discussion of the unique challenges faced by women with bladder cancer. My name is Anna Bradfield, and I will be the moderator for this discussion. The agency I represent, Wunderman Thompson Health, established a Health for Equity Centre of Excellence in 2020 that is committed to improving health outcomes for marginalised populations in partnership with the communities we serve and the clients we work with. As part of that commitment, in partnership with the Bladder Cancer Advocacy Network, we have an amazing group of panelists today who will be giving their personal and expert perspectives on the particular unmet needs of women with bladder cancer and what needs to change to better address those needs, as they share with us their vision for treatment and care in a rapidly evolving category. I'm going to let our panelists introduce themselves, if you would.
Good morning. I'm thrilled to be here. I'm Rebecca Johnson. I'm the Director of Research at the Bladder Cancer Advocacy Network, or Beacon. Beacon's mission is to increase public awareness about bladder cancer, provide educational and support services for patients and the bladder cancer community, and also to advance research. And so my role with Beacon is to oversee the suite of research funding and grants that we provide to further that mission and to manage the awards that we make once awarded.
Dr. Mcneil?
Yes, hello, my name is Brian Mcneil. I'm a urologist. I'm the Associate Dean for Clinical Affairs at SUNY Downstate Health Sciences University, and I'm the Vice Chair of Urology within the Department of Urology at SUNY Downstate. It's a pleasure to be here with everybody.
And then I believe we also have Dr. Avalova. Perhaps she's not able to join us this morning, but maybe Kim, you could introduce yourself.
Sure, I'd be happy to. So hello, everyone. My name is Kim Aldridge, and I am a bladder cancer survivor since 2018, and so doing very well and very happy to be alive here in 2022. I've spent about over 20 years or so in the pharmaceutical industry working in the oncology space. And so it was quite shocking to find myself as an oncology, or in this case, a bladder cancer patient myself. And so happy to be here and share my experiences to help improve the journey of bladder cancer for women like myself. So thank you for having me.
And Dr. Avalova.
Hi, I'm Dr. Svetlana Avalova. I'm an assistant professor of urology at Albany Medical Center. I have a special interest in treating bladder cancer, especially women with bladder cancer, and I'm very fortunate to be here today to join your panel.
Thank you. Well, Kim, let's begin with you. You know, you talked a little bit about being both an expert in the field and also a bladder cancer survivor yourself. What is your perspective on the unique and different experience and challenges faced by women? And obviously, you know, you can't speak for men, but would love to hear, you know, what it was like for you.
Sure, I'd be happy to. I was pausing at the term expert, but I'll do my best here. So I presented with symptoms of just pretty severe blood, and I call it Coca-Cola colored blood in my urine one morning back in 2015. Of course, I woke up quite scared, didn't know what that was. Went to the office anyway, and then found myself in the clinic there, and watching the nurse's face when she saw the color of my urine really scared me into that this is something quite serious. So for the rest of that weekend, I kind of tried to figure out what was going on. They diagnosed me, or treated me actually, with just a bladder infection. or UTIs is what they thought it was initially. And my body actually reacted to the antibiotics because the urine was no longer Coca-Cola colored. And so I'm thinking that I'm sort of getting well, I'm feeling better, although there's something in my system that's saying something's still not quite right, right? So I talked to my primary care physician, who did send me to a urologist just to make sure. And so he did a scope, looked at my bladder, and I just remember him kind of looking around and saying, I'm not really impressed by what I see. And as I've shared before, when I tell my stories, that phrase really stuck with me, because I've heard oncologists, when I do lung cancer panels, much like this, but I was on the other side, and just hearing a doctor kind of describe their experiences, and one used the phrase, actually quite a few did, I'm not impressed by what I see. And I didn't know what that meant, but it kind of stuck with me. He says, you're fine. All the labs look good. You've obviously responded to the antibiotics. So, come back if there's something more later on. Well, something more later on actually appeared in 2017, flying to Hawaii for a sarcoma meeting, blood in my urine again. At this point, I'm really quite scared, frankly. And I call my doctor from the airport, get to a clinic there. Same thing. I got treated with an antibiotic, came back to the States or to the US, and eventually did a biopsy that I had to insist be done with my urologist at the time. It came back positive, right? He said, there are things in my cases, Kim, in my lifetime that surprised me very rarely. Your case actually does, because for him, I didn't fit any of the signs of a typical bladder cancer patient, not even knowing what that was, frankly, because even though I was in the field of oncology and research and commercialization of new treatment options for patients, I didn't really do the due diligence for myself to go and find what bladder cancer meant, or what it meant to have all these symptoms in my body suddenly. But there they were. He's telling me that I've got bladder cancer. I'm a little freaked out. They take me to surgery 2 days later, and he gets it all out. It's early stage bladder cancer, just before he gets into the muscle wall there. And he got it out and then put me on a course of BCG for about 3 years. In the middle of that, though, I moved from Indiana to California. The way they treat and approach bladder cancer there, I found to be quite different. My bladder cancer doctor in California told me that, hey, if you had presented with these kinds of symptoms, I would have taken out your entire bladder. And I'm like, no, you wouldn't have, right? So because this is my bladder, I need to know you can't do that. But just that approach really scared me. At the time, you guys may recall, we were also running a shortage of BCG. So I kind of had to fight for the BCG. The doctor back in Indiana, they had me all set up in the system. I was getting it every 3 months like I was supposed to, as planned. In California, he's like, we don't have any. And I don't think you really need it. I don't think the evidence really supports maintenance therapy with that. And so, no. And I'm like, no, I am insisting, because when you're in that phase, you're like, oh my God, the guy in Indiana just saved my life. Now, maybe he missed it 2 years ago, but right now he's committed to saving my life, and I want to continue on his treatment plan. And so this guy eventually kind of yielded, and he gave it to me, because I was really quite insistent. And so I did do that and did the scope every 3 months. And I'm very happy to say that I was there early May, and I remained cancer free. Thank you, God. I'm so very happy about that. And so, yes. And so it's been an interesting story along the way. Initially he thought it was my fibroid in my uterus, quite frankly, pushing down on my bladder and causing the blood, because he's still a scientist and trying to think about, like, I don't really think this is cancer, but there is blood. There was a lot of it at one point, but it did sort of react to the antibiotics. So I'm not really sure, i.e. I'm not impressed, right? But still thinking in the back of his head, but not making a call at the time. And so when he did say it finally, I have to tell you that I wasn't completely surprised, because for me, there was something still going on in my body for those 2 years. I'll stop there, but I could go on, because, your life changes, right? It's like sitting on the other side and, being in the industry for over 20 years. And they talk about, it's sounding like Charlie Brown's teacher, when you have cancer, wonk, 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 you now have cancer. And I'm like, you're not talking about me. I'm on the other side of this, so. But I'm happy to say that I'm doing very well today, and very happy that we've got folks like, Brian and Svetlana. So thank you two very much.
Thank you, Kim. And Brian, Svetlana, could you reflect from your own experience, on that treatment journey that Kim went through, and, how you go about diagnosing and treating, especially women?
Svetlana, I'll let you tackle that first.
Well, first and foremost, I hate gutturally that this happened to you, Kim, because unfortunately you are one of many. Okay, your young age, your African American background. I mean, I applaud you for advocating for yourself, um, and doing what's right, and also having that gut feeling, knowing that something was wrong with your body. So that is kudos to you. But unfortunately, this is what happens to women, because more men, 3 times more likely men, get diagnosed with bladder cancer. We know that more white men get diagnosed rather than Black men. And because of this, and in addition, I will say, as we always say, bladder cancer is a disease of aging. So commonly happens where white men, usually in their 60s, 70s, are the ones that we see in the clinics with bladder cancer. And usually, unfortunately, they're still smoking cigarettes. They're not living the healthiest lifestyle. And so we have this typical bladder cancer patient etched into our minds that we usually expect to see in clinic across the table from us. And so the fact that this is happening to you and so many to our women across the country and across the world, we really need to raise awareness that not every patient is the same, that we need to have our antennas up. And if you are saying something's wrong, we've got to investigate. So I applaud you and kudos to you for fighting for your body.
I agree with you, Svetlana. And again, kudos to you, Kim. Oftentimes, when women have blood in the urine, everything is a UTI.
Right.
And you get antibiotics once, sometimes you'll get it a second time. I've even seen women get 3 rounds of antibiotics before making it to me so we can figure out why the blood is present in the urine. I guess the big takeaway for folks watching this panel for me is that if there's blood in the urine, it does not automatically mean it's a UTI. You should at least have a conversation with a urologist to get to the bottom of what's happening.
And Dr. Mcneil, could you talk a little bit about that, about the role of OBGYN, and the conversation that you have and how patients are referred to you, and potentially if there is a better path, especially for female patients?
Well, I actually look to obstetricians and gynecologists as our partners. They are our urology partners. Oftentimes we work together, and I have a good working relationship with gynecologists in the community, whereas if a woman does have blood in their urine, they will send them to me for a referral. I think that gynecologists are aware of the risk of bladder cancer, but some primary care providers are not. And I think that's one thing which may lead to the lag in treatment, diagnosis and treatment for some women.
That's great, thank you. And I know that all of us, when we're better informed, we can provide better answers and better solutions. So to that end, can you talk a little bit about the role of research and clinical trials in understanding and better addressing the needs of the female patient in the treatment of bladder cancer? And maybe Rebecca, I might start with you on that one.
Absolutely, thank you. So we know that there are still a lot of unanswered questions about women's experience and bladder cancer, and those range from questions pertaining to social determinants of health and what we've already heard from all of our speakers about differential timelines to diagnosis and to treatment, to a thorough, complete workup, and to access to care. But in addition to social determinant questions, there also remain research questions that need to be addressed about clinical outcomes once a woman receives treatment, whether that's with BCG or other immunotherapies or bladder removal or bladder preservation. And these are all active areas of study, but we need more definitive outcomes to help us answer these. and even past clinical outcomes, you know, and differential responses to treatment are quality of life outcomes that may differ for patients, and side effects to treatments, their experiences once they receive treatment, and extending to things like sexual function, which can be very different for women after receiving treatment than men. And so these are the types of questions that, you know, Beacon tries to help address through our programming and educational resources and webinars, but also through our research funding.
And I think through that funding, you know, you're in partnership, I believe, with a project that Svetlana is doing. Could you talk a little bit to that?
Well, I'll let Dr. Avilova
Please,
address.
Dr. Avilova, we'd love to hear about it.
We did support her in funding a project that is very patient-centered and came through one of our more patient-centered clinical research outcome awards. And we're thrilled to have this ongoing research, which we believe will help inform women bladder cancer patients, as well as the information we can provide to the community. So maybe I'll pass it to you to describe that project, Dr. Avilova.
Oh, thank you, Rebecca, and thank you for bringing up this super important and overdue project. This is looking at sexual function in women after they've received a radical cystectomy. However, the research actually starts in the beginning, right? So when women are scheduled for a radical cystectomy, we are trying to establish a baseline sexual function for them. And as we've all kind of pointed out, a woman with bladder cancer, let alone muscle invasive bladder cancer, or even high grade T1 bladder cancer, and due for a radical cystectomy, these are rare patients. And this is why we need to partner together with different sites across the country to bring our research forward. So that is what the current study is investigating. We have 10 different sites in the US from high volume academic centers, and we are looking at sexual function at baseline, so before they undergo this surgery, and then within the year after surgery at different time points. In addition, something super important and something that may influence different surgeons, like what you've experienced, Kim, recommending different treatments, right? So centers of excellence perhaps are more apt to do a radical cystectomy. They are more gung-ho, if you will, to offer that to you rather than other academic places or private practice places. So we are asking questions from the surgeons, exactly what they did, if they did that radical cystectomy, if they did pelvic organ preservation, what type of pelvic organ preservation. The usual dogma for a radical cystectomy, the radicality of it comes from removal of the ovaries, anterior vagina, and the uterus. Now, we all know that that could definitely affect sexual function. How does that do that for our women? We don't really have that information. So this is where the study really is trying to explore all of these different venues and figure out what it is that we need to study and how.
I can just sort of say, as a patient and just sort of listening to this part of the conversation, it didn't really occur to me about the connection between sexual function, sexual health, bladder cancer, and then my overall sort of reproductive organs, right? I didn't think about that connection at all. So I don't know if there's an opportunity in our process, in our journey, to bring that conversation closer together. Had my doctor not suggested, my urologist in this case here, the first time in 2015, and he could sort of feel that there's a huge fibroid there, and then sort of think that maybe that was the reason, which really surprised me. I have to tell you that, because for me, I'm thinking bladder has its own little separate function. My little reproductive organs have their own function. And so if I had to gone in and the first doctor had said, I'm going to take out all of this, and I would have fought and said no. But at the time, I really hope I would have done that, because you don't really know in the moment.
So Kim, tell us, what did actually happen around the fibroid diagnosis?
Yeah, so I've been carrying fibroids around, quite frankly and transparently, for I don't know 20 years, and so I got many friends who have them. They're very common in African American women in particular, and so mine were just they didn't bother me, and so I know they come back quite often, and so I just left them there until they became a problem, right? And so the problem was when he says, maybe that's the reason why you're having all this blood, and so I did in 2016 have the hysterectomy, right? And thought that was going to take care of everything. But then again, like I said, 2017, everything sort of, these symptoms they came back again. And so it was only because he suggested that, and I knew I had these, and I said, it's probably time to go ahead and get them taken out, that it was very easy for me to go ahead and say, yes, I'll do that. Had I been in a different stage in my life, right, I would not have said that so easily.
Thank you. That's very interesting. I wonder, Dr. Mcneil, if you have a perspective, on that kind of interconnection of symptoms and also recommendations.
Well, I think this speaks to the greater issue about quality of life and the way that we approach quality of life issues for women compared to men, and also sexual health. Sexual health is something that we're not very comfortable discussing, but I'll tell you this. If a guy had prostate cancer and we needed to cut off of half of his penis in order to treat his prostate cancer, everyone would be up in arms. But with advanced bladder cancer, the radical nature of removing the bladder oftentimes requires excising a portion of the vagina. Geez, how horrible is that? And lots of women have probably undergone this, not really understanding what was being done, nor how it would impact their lives. So I'm glad that we're having this discussion. I'm glad that we live in a day and age where people are more comfortable speaking about quality of life and sexual health. And Svetlana, I'm so happy that you and Rebecca are collaborating and doing this study. It's very important work.
Absolutely fascinating. And I think also, Rebecca, I believe that what BCAN does, one of the things that it does is provide tools and resources that better help patients to have some of these dialogues. Could you talk to that a little bit?
Absolutely. So any patient that visits our website can find basic information describing what bladder cancer is, the multiple treatment options, but also lists of questions to bring with them that they can print out to discuss with their physicians. There are numerous treatment talks and patient insight webinars or webinars provided by experts that address specific topics that a patient might find unique to their treatment or their specific diagnosis. And these are all recorded and made available on our website. In addition to the transcripts, if they don't want to watch the video, they can print off the transcripts and bring those into the visits with them and ask questions with their physicians. And in addition, Beacon offers a survivor to survivor program. So a patient or a caretaker can reach out to us, give us a little bit of information about their particular experience or diagnosis, and Beacon will help facilitate a match to a volunteer patient that they can talk through their experience and ask questions that way as well. So there are multiple opportunities and touch points that we can help provide.
Thank you. And I think, to all of you, thinking forward, in terms of these solutions, in terms of the diagnosis journey for women, do you have a point of view or some thoughts about, how would you design and define, what a sort of better future for women might be? Brian?
Yeah, so that's a great question. And I know that I'm a panelist, but I actually had a question from my other panelists. And you, Kim, I'm going to put you on the spot.
Okay.
One, thank you very much for sharing your story. And Svetlana, thank you for doing the work that you do. But Kim, what can we do better? And I'm not talking about female urologic oncologists, which we need more of, and I'm so glad that Svetlana is doing this work. But what can male urologists do better to identify with female patients and also to provide better care?
Wow, so that's a great question. I mean, the first thing I'm going to say, my gut response, my immediate response is diagnose me correctly the first time I walk into your office, right? So whatever is getting in the way of thinking that this is not quite bladder cancer for someone like me walking in your door, just kind of pause and dig a little bit deeper, ask some different questions that would maybe convince my doctor to, I don't know what he could have done, but I call it look a little bit deeper, right? Because there was like nothing in my history that would suggest anything like that, right? But he missed it. And so for me, the journey has to get better by him not missing it in 2015 and barely catching it in 2017 because I kept saying, we have got to do a biopsy. And so fortunately, he agreed, because I think he's like you two, a great doctor. Even despite all of that, I love my doctor. I will tell you that. I think he's fantastic, right? The guy here in California, well, we're still getting to know one another, right? So, but the guy back who saved my life in my mind, I call it saving my life. I just wished he would have done it sooner, such that I didn't have to go through the questioning of myself as to what was really happening with my body, although it wasn't related to blood continuing to come out of my urine, but something was off. So number one, help him kind of pause and ask him deeper questions, right? When everything else looked fine, should we have done the biopsy on day one? I don't really know. I don't know what would lead you guys to really make that decision. So I'd love to hear more about that from the physicians on the call here, the urologists on the call here. And then for me, just understanding, I didn't even understand, quite frankly, the kind of bladder cancer that I had. Now, again, when you're getting your diagnosis, you don't always hear. And, I'm sort of tuned to hear, but when it became about me, I wasn't hearing anything. And so just the whole, I guess, relationship between what we were just talking about, the female reproductive system, the sexual health. And now I'm like, oh, so that's the reason why I didn't know it at the time. But, there's all these things you don't put together at the time. So just a better explanation of the journey, of the treatment options, of the effects of that, and just the options. We didn't even talk about other options. He literally diagnosed me on a Friday and I was in surgery on Monday and wore that catheter. So if you can do anything else, is there another way than how to wear a catheter for 10, 12 days, whatever it was? But it's part of the process, right? And so I guess the best part is diagnose, treat early, discuss options thoroughly. You guys talk about clinical trials. For me as a patient, that sounds different. And I've been on the other side, as I said earlier, but as a patient with bladder cancer, talking about the opportunity for a clinical trial, I tend to think that, wow, there's nothing that can treat me right now. And so I'm kind of afraid to think about a clinical trial at this very first sort of opportunity to even think about cancer. And you want to go to clinical trial. And then again, from my experience, I know that there's an A arm and a B arm, and I want to make sure that I'm on that good arm and I'm actually getting treatment. And so am I a throwaway patient in that case? And so I think the way that that's actually brought up, you guys are very thoughtful about it, but I would continue to be very thoughtful about that, and particularly where that woman is in her journey of understanding her bladder cancer.
Kim, that's amazing. Thank you for that. I think you brought up multiple issues, the difference between non-muscle invasive and muscle invasive and having that clearly communicated. I think also, trial representation and how that's presented to patients. I think also something you brought up was the current options for treatment. I mean, really, you've talked about BCG and radical cystectomy. I wonder if we could have our doctors, reflect on those things. I think maybe beginning with the limited options currently, for treatment with bladder cancer.
Well, if I may, I would just love to bring it back to Beacon, because I have their Bladder Cancer Basics Handbook given to every single patient of mine with a diagnosis of bladder cancer. And that first visit, not to toot my own horn, but I literally review that booklet with them page by page. And I say, this is where you are. This is where we're looking to go. this is what may happen. And if it wasn't for that resource available, gosh, these conversations would be so tough, as I'm sure Brian could attest. They're lengthy, they're very complex. We have to be super cognizant of our patients' backgrounds, their educational levels, and kind of talk to them in a way that they can understand. And if it wasn't for that Beacon booklet, I would have a really hard time doing that. So kudos to Beacon once again for making that available to us. And then oftentimes the second visit, the patient brings that booklet back and says, Doc, I have it. These are my questions about it. Can we go over this part again? So I do think we're on the right track of, first of all, having that information available to the providers to review and for the patients to take back home to review and come back again with questions. That active, we talk about active listening, active learning, that doesn't stop in the classroom, right? Like we need to continue to do that in our clinics.
If I can just add on to what Dr. Avalova said, the Bladder Cancer Basics Handbook is a great resource, and from there can serve as a jumping off point for patients to dig in further to Beacon's website and find specific webinars or treatment talks that cover the type of treatment that they've discussed with their doctor, etc. But also to go back to a point that Kim made, it talks a bit about clinical trials, and we do think that clinical trials should be part of the discussion with physicians, and part of getting to that point is awareness. You can't have that discussion if you're not aware of them. And another resource that Beacon offers is a clinical trial dashboard that patients can look at on our website that shows them trials located near them that are appropriate for their diagnosis. And if they're unsure, patients can also print those out and bring them into the office and have those discussions as well. And it may not be appropriate as the first line discussion, but it should be something that they're at least aware of and can put on the table to talk about.
Kim, was that anything that was discussed with you at any point during your journey?
In terms of clinical trials? Never. Not once. And I never thought to bring it up. Again, my mind was someplace else, obviously, at the time. But no, and I was thinking about the handbook that you just talked about as well. That would have been great to kind of sit down and do that. It takes time, obviously, but to do that in the detail that you just talked about, Dr. Svetlana, I hope I'm saying your name right. I had a little pamphlet, the little kind of, brochure thing. And here's a picture on his wall. And that's it. In fact, we actually never looked at, once I got the final diagnosis there, we didn't actually go to the wall and say, this is kind of what you have. He just said, you're scheduled for surgery at 10 o'clock on Monday morning, and don't do this before you get here kind of thing. But that would have been a good time to sort of sit me down and talk me through what the options were, give me a better understanding what I was about to go into and what the possible outcomes could be. We didn't do that. Looking back on it, I was probably fine. I just wanted to let's get this thing out, whatever. I'm mad at you because you missed it. So now you better take care of me and give me your best shot here. And that was kind of our relationship at that time. And I still pause on what is the best time, when is the best time. Certainly having a handbook that's very detailed like the one you just described, I would have taken home and read. Now, did I do that? No, I would have given it to a friend of mine to read it back to me at the point, because you're really, and I was so surprised at myself that I didn't really want to know a lot of stuff. So I say what I want to know right now to you retrospectively. But at the time, I was very capable of going and sort of looking it up and asking additional questions, but I did not. And I'm still kind of floored at myself for not asking more at the time. I asked more today than I ever did, but the handbook sounds fantastic and be the kind of way that I normally would like to learn. And so, again, I just want to say applaud you guys for doing that and trying to find ways for patients like me to get that in the moment when we need it.
I will just say, if anyone listening would like a copy of the handbook we're talking about, they can go to bcan.org/handbook. And it's available there on our website in electronic and in print form.
I think it would be nice, again, if we're talking about what can be done, you know, as we're sort of going through this journey, but at some point, you know, could my doctor had said, hey, go to Beacon, they've got all these great resources. So he didn't do that either. But I think that could be something that would sort of, you know, augment the information that he was giving me sort of verbally at the time. If you have no questions, you can go to this website, or something that I could give to like, you know, the friends of mine that were around me at the time. So I'm like, what? Like, what is bladder cancer? It's so rare. Like, how did you even get that? We didn't talk about that, right? I had a lot of friends say, that's bladder cancer. It's kind of like, it's almost like, it's not real cancer kind of thing. It's not lung cancer. It's not breast cancer. But it certainly was cancer, and we didn't understand because we never really heard about it before, frankly, because it is rare.
So I think that's very interesting, both in terms of caregivers. Were you given any access to networks or communities? Because I noticed Beacon talked about that as well. And how would that might maybe have changed things?
Again, timing is everything, right? So I think in 2015, I probably would have leaned into more understanding because there was still something going on that I wasn't quite sure of. And perhaps I would have gone back even sooner, before even the next presentation of blood, right, in my urine. So I think and maybe, you know, it wouldn't have been just sort of, you know, like a rush, scare me to death, get to surgery kind of thing. Maybe there would have been another option. I don't really know. But I think at the very beginning in 2015 would have been the best time for me to be the best informed about my whatever was going on, whatever the possibilities could be. But then how does a physician do that? How does a urologist do that without scaring the patient into thinking that, oh my God, it's cancer, and I can't really tell you, we haven't diagnosed or had a path report that says it is cancer. So it's kind of like this fine line. So I don't know when you guys decide to do that, but why would you do that before having a diagnosis? So I don't know how to answer that one. So I think those are still questions that I have.
So I do think that a few points were mentioned here, and I think this is worth restating. You know, intermittent, which is what you had, it came and it went.
Yeah.
Intermittent gross hematuria or blood in the urine, just because it's intermittent, just because it comes and goes, that doesn't mean it's not there.
Right.
And that awareness, we have to get better about improving that awareness. And the analogy I use is blood in the stool. We all know that's not normal, right? And our colon cancer colleagues, they have done an amazing job of improving awareness, of educating our primary care physicians and providers to make them aware. This is not normal. Well, the same as blood in the urine. It is not normal. And so increasing awareness, increasing research money allocation for bladder cancer research is of utmost importance. And so, you brought up some cancers that are popular, right? Because they're more common. And so bladder cancer is only, I would say, 4th to 6th most common cancer in the US, but it is still in the top 10 and affects a lot of people. So we really need to increase awareness.
Completely agree on that. And you made me think about, I had blood in my stool a couple of weeks ago and was rushed to go and get a colonoscopy like ASAP. And if I think about the difference in kind of how the bladder cancer was treated, it's very different.
What do you think is driving some of that difference?
Myself as a patient, I don't really know. I'll just sort of speculate that maybe we understand the importance of colonoscopies. Maybe the literature about, what you need to do when you see blood in your stool is just more prevalent. We're just more aware of it. So I think it does come back down to just pure awareness. Like I had never really paid attention to, to bladder cancer until it sort of hit me, even though we were working on a drug at the time at my company for bladder cancer. Just didn't really think about myself in that context. So we were also working on one for colon cancer too, but now today you get these little kits in the mail for colon cancer. We've done a lot to actually increase the noise around colon cancer. You don't have that same kind of noise around bladder cancer. And it being in the top 10, to me, we should have that same kind of noise.
That's really great. And I think a lot of, the things that you've all mentioned are really looking to this. But I was wondering, are there any other thoughts that you would have for a vision of the future, especially for the female patient diagnosed with bladder cancer? What would best look like?
I think Brian has his hand raised.
Oh, Brian, please.
So, I think that the future looks bright for women with bladder cancer. And actually, one of our panelists represents that future, Svetlana. Full disclosure, Svetlana and I have known each other for a decade, if not more. And when one thinks about an underrepresented minority, or, they're underrepresented minorities in medicine, and they're also underrepresented minorities when you look at patients, and this leads to healthcare disparities. Kim, you're a woman. Women aren't, diagnosed with bladder cancer as often, and you're an African-American woman. So you're like a double or whatever you want to call it. Mansplaining is prevalent in most aspects of our life. I figured I'd bring some comic relief. And I think that I speak on behalf of all of my urology colleagues within the American Urological Association and the Urology Care Foundation, and saying that we've realized that the treating physicians need to mirror the populace, the patient populace. So we've made huge efforts to recruit more women to our field. And I think that urologic oncology is a field, the urology specialists that focus on cancer itself, we're trying to recruit more and more women to the field to identify and treat patients like you, Kim. Mm-hmm. And, again, Svetlana, I'm so proud of the work that you're doing. And, it's amazing when we think about the future. I think that we should look at Svetlana. Don't mean to make you blush, but hey, that's how I feel.
That's amazing. Thank you. And Kim, Rebecca, how important is it to see more women, as providers for especially women, coming into this?
Yeah, I think it's very important, right? I think because maybe I'm thinking the woman would automatically think comprehensively about my entire body, right? Not to say that a man doctor, a male physician would not do that, but particularly with bladder cancer and the, the proximity of just sort of, the female reproductive hormones or system, if you will, set up, maybe that conversation would have been had. Maybe. I don't know, Brian, what your thoughts are on that, but if I think about, the advantage of going to have a female urologist, that's the first thing I think about as the greatest benefit.
And, Rebecca, on your side, I don't know if the groups or the survivorship are partnered, by male and female, or if you're able to provide, female urologists to female patients, maybe that's something potentially that you do or in the future.
Sure. The survivor to survivor program pairs patients together. So we certainly can, if we have a female patient, they request to speak to another female patient, we absolutely will do that. We try to be as inclusive as possible so that that volunteer pool is composed of men and women. But we also can, if a patient reaches out to us or a caregiver, Beacon tries to work with as many urologists as possible and touch as many care practices as possible. So like Dr. Avilova said, we have physicians that are referring patients to our resources and to our information, and we work with a wonderful cohort of medical oncologists and urologists who do that and who provide Beacon information. And so the more women urologists that we can bring on board into the Beacon community, that's even better. and the more awareness we can provide for patients and for women specifically that this is something that can happen to women, even though the incidence is much lower. That's the goal. It really starts with awareness so that patients are able to advocate.
I can add one more comment to that. It would be around the comment of my doctor in California wanting to take out my entire bladder. If I had presented with what him initially, right? And I don't know if a female urologist would have been more sensitive to what that would have done to my life had I not sort of said what, and he'd gone ahead and done that. But just kind of making a statement like that, in my mind, it felt like without any regard to my life. We're just talking about, okay, I'm going to do all I can to save this the bladder cancer thing, treat that. That's what I do, kind of. And if it requires taking out the bladder, that's what we're going to do here. And no mention of what comes next, if that were the case at all. And so just again, for me, part of improving the journey is to make sure we understand clearly the impact of the treatment options, particularly around, full removal of bladder.
I think that was something you'd said, Brian, as well. I think it's very difficult with a cancer diagnosis to also consider quality of life and to ensure that that is part of the discussion.
Yeah.
I think the other thing, it's been an absolute privilege, to listen to you all. But something I feel is very valuable is having discussions like this, where there are different voices in the room and putting those perspectives together. As I say, things have come out of this simply by your interaction that, we don't always hear in our own disciplines.
Yeah, and just to, if I may add to Kim's comments, some of us may say those things, right? Because we want to show you that we're capable, right? And that you came to the right place. And if we need to pull the trigger, then we can. But we really need to, take a step back and hear what patients say also. And this is where, again, to Anna's point, like hearing you say how it affected you, I'm going to think twice before ever saying that as like the starter to our conversation, right? Yeah, that is, talk about like the foreplay before the but so and so it's so instrumental and so instructive that we have these discussions, again, to Anna's point, and bringing the patient to the table. And again, not because I'm being paid by Beacon to say this, but I feel like they do a really good job of engaging patients and having advocates such as yourself, Kim, to help us understand that and to help us learn that.
Keep it up, Rebecca.
Thank you. Yes, and we, in addition to patient advocates and awareness, we're really pushing to advance the research dollars in the space as well. As we've heard from the discussion previously, there is a gap between the prevalence of bladder cancer compared to other cancers and the amount of research funding that's available in this space. And so that's a key focus of Beacon as well, to help fill some of those gaps and answer questions through our research funding, such as the ones we've been discussing today that particularly pertain to women.
Well, thank you all for a really great discussion. I'd love to open it up to any closing remarks that you had. Any last thoughts?
I guess I'll just start by saying, one, again, to Rebecca's point, thank you for holding this conversation. I think it's incredibly helpful for advancing how a woman in her bladder cancer journey is. I think there's an opportunity for it to get better. And we do that by having these conversations, by understanding kind of where things may fall off as part of the journey, where we can sort of tighten up around it, right, to actually make sure we can lead towards better outcomes. And I don't know if there's a goal of sort of making it, you know, on the same level of awareness as the other top 10 cancers. But I think the more we talk about it, obviously, the better opportunity there is to do that, which I think is the absolute key. And so that, you know, like someone like me, I'm not completely shocked as to, you know, like, what is that? How did I get that kind of thing? And, you know, helping to understand and explain that to even my family members and friends who don't understand, like, you know, what did you do to get bladder cancer? It's so rare. It's so weird kind of thing. So to me, it's just the continued awareness. It's the continued, I think, sensitivity of the urologists that we have on the call today to want to pause and listen to people like me and our stories. And so I thank you two for being willing to do that and take that back to your individual practices. And so I feel very blessed to be a part of the conversation today. And so thank you all very much.
I think that's a lovely way to close, and it really has been such a pleasure and a privilege. We will be sharing out the link to this recording for anyone that wasn't able to tune in. And then we're also going to have an award to come for Kim to acknowledge her bravery for sharing her story. And to anyone that is on and our panelists, we hope you will pass on this session to your network, and really look forward to reconnecting with you, working together towards that, you know, let's put bladder cancer on the map, and you know, really understand and highlight the needs of women within that. But thank you all for your time, and I hope you have a wonderful rest of your day.
Thank you. You too.
Thank you.
Thank you so much.
Thank you.